I've now request Dr. Mukulesh to take over.
So, thank you very much. And it's a privilege and opportunity to share my thoughts on protein, which is so very important and central to our diet, our life, our existence. So, basically, it's a very simple topic, and to speak on a very simple topic in front of August gathering is really a difficult task. Talking on difficult topic is easier, but talking on really simple topic becomes difficult. I've tried my best to communicate some updates in this area of protein and diabetes so that this time is utilized in the best possible manner. We are all aware that diet and exercise are the key factors for the control of diabetes, and there is greater emphasis on calorie restriction, fat restriction, and dietary fiber increase in diets. And protein intake recommendations, they are no different than general population as far as diabetic population is concerned. But still, balanced protein diet is now recommended for optimal glycemic control, weight loss, appetite control, and satiety. High protein basically improves insulin sensitivity by preserving muscle mass, and consumption of protein nearly 1.6 grams per day, or that contributes to somewhere around 20 to 30% of energy intake, that reduces the loss of lean body mass. Energy restricted high protein, low carbohydrate diet reduces body weight and improves glucose control in diabetes. And a balanced protein diet induces greater reduction in fat mass in both men and women in patients with diabetes. So now coming to what is the impact of protein in diabetes. It is really having a minimal impact as far as blood sugar is concerned compared to carbohydrate, and but it will lead to regulation of blood sugar levels by promoting satiety and reducing the rate of digestion and absorption of carbohydrates. So probably direct impact on the control of blood sugar is not there, but indirect effect of that is happening on the blood sugar is certainly there. Now, including proteins in meals and snacks has got effect on the spikes or the glycemic variability or the jumps what the person's sugar is going to be after food intake. That is something which is blunted with the use of protein. It's important to choose lean sources of protein and monitor protein portion sizes to avoid excessive protein intake. Protein intake can also support muscle health, which is important for individuals with diabetes. So let us just briefly revise our knowledge. What are the common sources of proteins? They come from animal protein and the plant protein. The animal sources we all know are meat, poultry, fish, egg, and milk. The plant sources, basically, they come from the pulses such as lentils, green gram, horse gram, black gram, chickpeas, kidney beans, cowpeas, soybean, and green peas. They are all resources of protein, but other sources such as nuts and seeds, almonds, pista, cashew, walnuts, hazelnuts, chia seeds, pumpkin seeds, flax seeds, sesame seeds, they are also containing significant amount of protein. I have mentioned this slide because there is a trend of shifting from animal protein to plant protein. So we should understand that these are the sources which are available to us, which can be substituted in the diet of a person. Now, what has changed? So the protein intake recommended for long is 0.8 gram per kg per day, and it is based on young healthy men. The protein consumption of nearly 1 to 1.5 grams per day in older adults is able to induce improvements in glycemic control and muscle mass. What the science has taught us is that there is no evidence that adjusting the daily level of protein intake, typically 1 to 1.5 gram per kg body weight, or 15 to 20 grams of total calorie, that will improve health, and research is inconclusive regarding the ideal amount of dietary protein to optimize either glycemic management or the cardiovascular risk. So this is in contrary to what we understand. So what has to be done? We have to really, therefore, individualize the intake of protein in our patients. Of course, there are some research which have found that adding protein to the diet that increases the satiety and through which it certainly helps the diabetic individual. Now, talking about protein and kidney disease. Once again, historically, what we know that low protein eating plans were advised for individuals with diabetic kidney disease with albuminuria or reduced estimated glomerular filtration rate. However, the current evidence does not suggest that people with DKD need to restrict protein to less than generally recommended protein intake. Reducing the amount of dietary protein below recommended daily allowance of 0.8 gram per kg is not recommended because it does not alter glycemic measures, cardiovascular risk measures, or the rate at which the GFR declines, and may, on the contrary, increase the risk of malnutrition. So we have to be careful that reductions less than 0.8 gram even in kidney patients is something which is not suggested or recommended as of now. Now, there is a lot of debate around the types of protein. Even though the animal proteins are good proteins, their long-term red meat consumption can increase the risk of chronic diseases. Now, with that fact in the background, there is a trend from transition of animal proteins to the plant-based proteins, substituting animal proteins, but maintaining the nutritional demand is required for this. And as the name refers, the plant-based proteins, they are proteins found in plant food sources, whole grains, legumes, and nuts. So there is a strong evidence that suggests that high plant protein intake and replacement of animal protein with plant protein is associated with low risk of all-cause cardiovascular mortality, and that has come from this Women Health Initiative cohort study, and it is a reference which is there in ADA 2024. If we talk of another meta-analysis which has included 13 RCTs, replacing animal protein with plant protein leads to a small improvement in A1C and fasting glucose in individuals with type 2 diabetes. Though it's minimal, but that impact is still there. And then plant proteins, they contain lower saturated fat. So for these differences, probably there is shift of substituting the plant proteins for animal proteins. But there are certain issues with the plant proteins. Protein intake certainly should ensure that we are consuming enough dietary amino acids, and these amino acids should be comprising of the essential amino acids also. So 20 of them we are aware, 9 of them are essential, but 4 of these 9 are deficient in the plant sources. So therefore we have to be careful, and here is the list which are deficient and what amino acids are deficient in what plant protein. Grains like cereals and millets, they are deficient in lysine, threonine, and tryptophan, but we can complement it by adding pulses to it. So the pulses, they are deficient in methionine, but they contain enough amount of lysine, threonine, and tryptophan. So this is how we have to go, that we have to see that the vegetarian diet should be combined with cereals, pulses, nuts, seeds, and milk to have all essential amino acids as the component of diet. With that reference, we come to a very interesting protein, and that is soya protein. Now, this soya protein is historically identified as Asian region protein, and this is having significantly low glycemic index, and therefore, this is something which is very important to understand. Plant-based protein, which is containing enough amount of essential amino acids as well. It is suitable for persons with lactose intolerance. It reduces blood glucose because it has got low glycemic index of 14 to 20. It reduces blood cholesterol, including the LDL-C and triglyceride. It prevents obesity and belly fat by its metabolic effects. Does not cause stomach upset or indigestion, and it's friendly for both vegan and vegetarian subjects. Additionally, it contains isoflavones that protects from kidney dysfunctions, including the patients on dialysis. And there is a meta-analysis of 12 studies which has demonstrated that it is working well in patients with CKD in reducing proteinuria, reducing serum creatinine, reducing BUN, and additionally, very importantly, also reduces C-reactive protein. Now, with this C-reactive protein, which is an inflammatory marker, I will like to bring your attention onto this slide. Recent studies as far as the addressal to LDL is concerned, we are all aware about the Improve IT 4-year SPIRE study. They have addressed to triglyceride. And what you can see on the right side of you is the Cantus, Colcott, and Lodoco 2 trials. They are basically targeting the inflammation. And what results we have got with the use of colchicine and an IL-6 inhibitor, that is canakinumab, the results are much better than the direct addressal to triglycerides or the lipids. And this is why now the current algorithms, they will be including HSCRP as one of the components to understand what we have to do with these patients, those who are having high HSCRP, and their addition of colchicine as a routine medication is something which is going to happen. FDA silently, without any hue and cry, has already accepted this as class 1 indication to be used in patients with ASCVD. So, anything which can give you reduction in HSCRP, addressal of inflammation, that is something, and soya protein is one protein which is capable of doing that in the background. So, you can get additional benefits with the usage of such protein. Now, I'd like to answer a couple of questions. These are questions which come to us when we are sitting in our OPD. Will just protein consumption help build muscle mass? The answer is clear-cut no. Because dietary protein alone is not utilized efficiently, it has to go with good amount of carbohydrates and fat. Secondly, it has to be complemented with exercise. So unless and until the person is exercising, it is not going to be assimilated in the body. Now coming to this second question, and that is another common question which is asked to us: should we supplement ourselves with protein powders? So these protein powders, the sources basically they come from egg, milk, or whey. Whey is byproduct of cheese or paneer. Plant products like soya beans, peas, or rice, but they have added sugars, non-sugar sweeteners, non-calorie sweeteners, flavoring substances, preservatives at times. And then whey sources, they have good quantities of branch chain amino acids. And here, recent studies have revealed that branch chain amino acids can increase certain non-communicable diseases. And therefore, consuming high quantities, more than 1.6 grams per kg, is associated with only small increase in muscle size and strength along with resistant training exercises. And therefore, what is the recommendation? And these recommendations come from ICMR recently declared, released document in 2024, that consuming high level of protein, especially in form of protein supplementation powder, is not advisable. So this has to be understood that what quantity we can go to the max. Beyond that, probably should not be done. So just to brief about this document's recommendation, cereals have lower levels of lysine and higher levels of sulfur-containing amino acids like methionine and cysteine, and the reverse is true for pulses, and therefore a combination of the cereals with pulses in the ratio of 3:1 will improve the quality of protein in the meal. And most athletes, they can get recommended amount of protein through appropriate selection of food items. Protein powders are unnecessary and they can cause harm. Prolonged intake of large quantities of protein powders or consumption of high protein concentrate has been associated with potential dangers such as bone mineral loss and kidney damage. So we have to be careful about these things. And a small liner coming from ADA 2024, when we are treating hypoglycemia in our patients, and if suppose we are giving a carbohydrate thing which is containing good amount of protein or high amount of protein, there is a word of caution here, because ingested protein will lead to increase in insulin response without increasing the plasma glucose concentration. So any of such item which is containing high amount of high protein, that has to be avoided. So probably it is to be more of concentrated carbohydrate. So this caution is there in ADA 2024 regarding the protein use. And now coming to the impact of protein in our lives. We know that we all are going to age, and with age we are going to lose our muscles. There is a gradual age-related decline in the muscle. And if we talk of differential, then the lower body loses more weight, more muscles as compared to the upper body. So we have to exercise them so as to maintain the lower body lean mass. So what is lean mass? Lean mass is basically all body weight, excepting the fat that is approximately 75% of the body weight, and of which 50 to 60% is the muscle or the lean body mass, skeletal muscle mass. So averagely, if we talk of our body weight, 35 to 40% is the muscle. And we lose this muscle at a rate of nearly 10% per decade beyond the age of 30 years. And this goes up to nearly 15% per decade, that is 1.5% per annum beyond the age of 60 or 70 years. And we know that we all are aging, and our average life age expectancy is also increasing in India. Now coming to what this muscle changes basically occur. It changes in the quantity, but it's just not the quantity which is affected. It's the quality of the muscle that is also getting affected with the age. It gets infiltrated with fat, that is ectopic deposition of fat known as myosteatosis, and lot of fibrosis happening inside the muscle. So this muscle loss is the new malnutrition challenge in clinical practice, and it is just not a challenge. It is accepted as a disease by WHO by the code that is M62.8. And the prevalence is more in males and less in women. Coming to muscle mass and diabetes, we know that the muscle mass loss happens with aging, but once the person is also having diabetes in the background, they lose these muscles faster than patients, those who don't have diabetes. We also know that muscle mass is the largest storage of depot for glucose in the body, accounting for nearly 75% of glucose disposal, and decreases in the muscle mass have huge implications on glucose handling by the decrease in glucose storage capacity. And if we try to measure it, 3% incremental increase in muscle mass is associated with a 7.5 relative risk reduction in pre-diabetes risk. And therefore, once we are talking of remission of diabetes in patients, those who are obese or overweight, we have to be focusing on to this component also, and that is muscle, along with taking care of the extra fat in the person. Why should we be maintaining good muscle? And that is because maintaining high muscle mass improves insulin sensitivity and decreases the risk of diabetes, stroke, and heart disease. At the same time, it also takes care of bone health. It also takes care of the muscle health, and basically, it also delays aging. So maintaining good muscle mass is really important for all these factors. But we know that sarcopenia is something which happens, and it is going to happen in everyone. But the definition of sarcopenia now involves low muscle strength, low muscle quantity and quality, at the same time, low performance of these muscles. So all these three components make the definition of sarcopenia. And the sarcopenia is then responsible for morbidity, mortality, disability, more falls, frailty, and then adverse outcomes once the person is admitted into ICU. So all these factors are associated with sarcopenia. So sarcopenia is both cause and consequence of type 2 diabetes, and it contributes to further progression of diabetes through altered glucose disposal due to low muscle mass. And patients with diabetes have threshold which is threefold higher in sarcopenia as well as sarcopenic obesity when compared with non-diabetic individuals. Given that protein is essential for building muscle, paying attention to protein intake is important for diabetic management. Now, BMI is something which we use in our day-to-day practice, but is BMI correct thing for knowing what exactly is the composition of body? Now, if you see this graph, we have a linear relationship between BMI and the free fat mass index. But if you see the scatter at any point, the dots are on both sides of the line, and therefore it speaks that it is not the correct estimate of the body fat index. Sarcopenia, once it is coexisting with obesity, it is known as sarcopenic obesity, and this is something which is very, very central to Indian subset of population. This is new category of obesity in older adults who have high adiposity with low fat mass. This is sarcopenic obesity in Asian population. It is a distinct entity because we consume high energy food. We are doing less of physical activity. We have thrifty gene, more of dyslipidemia, more of insulin resistance, and then more tendency to central obesity. All this basically culminates into gathering more of sarcopenic obesity in our population. Aging and obesity through various mechanisms, it gradually goes on to produce sarcopenic obesity in Indian population specifically. For this reason, I have written this chapter, which is available internationally in a textbook of advances in geriatric and gerontology. Lot of it is discussed in this chapter on sarcopenic obesity, which is freely available on internet. Before I end, there is another contribution which can be added to the management of the sarcopenic obesity or sarcopenia as such, and that is this lysine, which is having its active metabolite by the name of HMB or beta-hydroxymethyl butyrate. But the problem is consuming leucine is not enough because only 5% of the leucine converts into HMB, and this HMB is the active metabolite which is responsible for building up of the mTOR units in the muscle, which is responsible for muscle building, and the muscle degradation goes down through the mechanism NF-K beta. And therefore, this HMB is something, if it is added to protein powders, that can add value as far as the sarcopenia addressal is concerned. So this is my last slide, that we know that our actual age is what our vascular age is. This is what we have learned. But your muscles, they will determine your quality of life during the golden period of life. So gain, retain, or at least don't lose them. Muscle is the key. It is the mislink. Take care of yourself, because the most precious gift you can give to your family is healthy. Thank you so much for your patience.